Suffering from bad breath is a social handicap. It's fraught with emotional and psychological distress. Some suffer the delusion that others readily detect the odor and feel constantly uncomfortable around other people. It's likely that the majority of adults suffer from bad breath at least occasionally. People with this kind of problem often develop an oversized idea of how bad it really is. Some are suffering from what's called halitophobia, imaginary bad breath. It can be as disabling as the real thing and has to be treated in order to convince the patient that he or she is odorless, or at least that the odor can be controlled. This results in an obsessive behavior of repeatedly brushing one's teeth, using mouthwash and mouth spray, constantly chewing chewing gum or breath mints, clothes changes, and using lots of deodorant. This often leads to problems at work or in relationships, and sometimes social withdrawal. To suffer from bad breath occasionally is not to be mistaken for halitosis.
Bad breath is no joke to those who have it. It's a constant source of embarrassment and shame. And yet statistics show that 70% of the population either has halitosis or worries daily about their breath. So it's the responsibility of every dentist and hygienist to inform about, diagnose, and treat this condition. Because today, after 20 years of research, we know what the cause is, and we have the cure. In ancient times, in Africa, India, Arabia, and South America, tongue scraping was part of a daily cleansing ritual. By keeping their tongues and their mouths clean, people kept their bodies pure and kept evil away. Well, these days we have more sophisticated tools, but they work in much the same way. And this method has proved to be the most efficient for getting rid of bad breath. This is the old tool. A simple twig from the forest. This is the new. How does this concern you? Well, it means more and often highly satisfied patients and a new source of revenue for your practice. Since the procedure is non-invasive, the fear factor is reduced and patient compliance is increased. Fresh breath means improved self-esteem for them and better self-confidence, and they'll associate a visit to your practice with something extremely positive.
Here in the West, people didn't pay much attention to the problem of bad breath. But there were exceptions. In 1896, a man called Howe published the first book on halitosis. And in 1920, J. Sarrazin presented bacteriological evidence that the tongue was covered with staphylococci and streptococci. He claimed that the tonsils, teeth, and gingiva could be contaminated and infected by bacteria from the tongue, and he recommended daily tongue scraping. Until a few years ago, few scientists were inclined to take serious academic interest in bad breath. Those who did were regarded with skepticism by their colleagues. But in 1993, Professor Mel Rosenberg and some scientist colleagues arranged the first world workshop of oral malodor in Israel. That meeting clearly demonstrated the need for more research, and as a result of that, another workshop was held in Belgium in 1995. It was a critical step towards recognition of breath odor as a legitimate and important field for dental and medical research. The workshop was attended by 140 experts from 14 countries, with major television and newspaper coverage. At the conclusion of the meeting, the attendees agreed to establish the International Society of Breath Odor Research. The society would publish a periodical newspaper and further help research and dissemination of knowledge on breath odors. In the past, bad breath was often considered to be an incurable affliction. The common belief was that it originated from the stomach and was caused by indigestion. This idea is not supported by research today. Only a few % suffer from bad breath caused by gastrointestinal problems. Digestive problems will lead to an excess of sulfur-producing bacteria, but in healthy people, the only time the stomach can cause a problem with your breath is when you belch. This is because there are valves to prevent air escaping, and the esophagus is normally closed. Cellular degradation and decreased saliva produces an anaerobic environment and bad breath. Mumps, ascending parotitis, uvioparotid fever, parotoid abscess, all decrease saliva production, contributing to dry mouth and halitosis. Infections of the cheeks, maxilla, and mandible. These anaerobic infections are described as especially foul-smelling. Anaerobic lung abscess, necrotizing pneumonia, and emphysema. The symptoms of halitosis originate from aspirated mouth flora. One type of deficiency is when the patient has an excess of trimethylamine. The liver cannot metabolize it, and breath, sweat, and urine become fishy smelling. Common for systemic illnesses such as diabetes, malfunction of the liver, and kidney disorders are the metabolism effects on fat, protein, and carbohydrates in our system. There are characteristic smells for each illness, such as sweet acetone, a fishy smell, and a fishy metallic smell. How can you determine if the patient is suffering from any of this? Well, you can't, but by examining and questioning the patient, you can exclude symptoms from the oral cavity and refer the patient to a physician for further diagnosis and treatment. When confronted by a patient complaining of bad breath and underlying causes are ruled out, halitosis is usually a sign that an abnormal condition exists, awaiting diagnosis and treatment. Dr. G Wahab, you're a dentist and founder of the Breath Clinic Stockholm. What is it in the oral cavity that causes bad breath?
Well, we have about 500 different species of bacteria in the oral cavity. Some of these bacteria are used for the digestive system. Others we know very little about or even nothing about. What we do know is that it is the anaerobic bacteria that does produce bad breath.
What causes the foul smell?
Well, the anaerobic bacteria uses amino acids to start a bacterial degradation, and it spreads out an odorous foul smell or sulfur gas into the air. It is two substances that we know of today that do account for about 90% of the total amount of gas in the oral cavity, and that is methyl mercaptan and hydrogen sulfide. These two are called volatile sulfur compounds, or abbreviated VSC.
What does volatile mean in that context?
It just means that you can smell it.
What are you looking for in your oral examination?
Well, we're looking for all areas in the oral cavity that can harbor these anaerobic bacteria. It could be periodontal pockets, around crowns and bridges, faulty restorations, and even around pre-erupted teeth and so on.
Isn't it anaerobic bacteria that cause gum disease?
Yes, we've seen in patients with gingivitis and periodontitis that they have high levels of anaerobic bacteria in their mouth.
This reinforces the need for good oral hygiene, obviously.
Yes, it's very important.
How about the function of saliva in combating halitosis?
Very, very important. The saliva has four major functions. Number one, it provides enzymes to the oral cavity. Number two, it stabilizes the pH value in the oral cavity. Number three, it provides high levels of oxygen to the oral cavity. And number four, it cleanses and rinses the mouth and tongue.
This means then that mouth dryness would be a problem.
Yes, it's a very big problem, but it's caused naturally in most cases. And for instance, during sleep, between meals, long hours between meals, and for instance, dieting.
If those are the natural causes of mouth dryness, are there any other factors which cause it?
The people on prescriptive medications, and people that drink alcohol, and even mouth rinses containing alcohol.
So mouth rinses, which are intended to stop bad breath, can actually cause it?
Yes, we've seen in many cases that people using mouth rinses with alcohol that initially they get a better breath the first 15-20 minutes. After that, the alcohol in the mouth rinse dries out their oral mucous membrane and get a worsened breath.
Are there any specially formulated rinses which are effective?
Well, today we know of two very good substances that are used, and that is chlorine dioxide and zinc. Chlorine dioxide kills the bacteria, and the metal ion zinc binds the sulfur gases and gets rid of the smell.
Continuing your dental examination, do you now move on to the tongue?
Yes, well, the tongue is the single largest area in the oral cavity, with its papillaries harboring all these anaerobic bacteria, which is covered by the plaque of the tongue. We also look at the tonsils and in other places, as we mentioned, periodontal pockets, round faulty fillings, and so on.
So when these bacteria are activated, for example, when with the introduction of proteinaceous foods, degradation begins and bad breath occurs.
Yep, that's true.
What can be done to prevent this?
Well, we can start by adding tongue scraping to our daily cleansing routine, and in severe cases, even maybe complement it with a mouth rinse containing chlorine dioxide.
Another phenomenon is postnasal drip. What's the connection between postnasal drip and bad breath?
We've seen that the nasal secretion is very thick and sticks onto the back of the tongue, and in those cases, a very foul odor can be smelled.
Can anything be done about it?
Yes, we recommend those patients to use a nasal spray to dissolve the secretion, and so it can slide down the tongue and swallow it.
Can sufferers from postnasal drip be helped by the specially formulated mouth rinses?
Oh yes, all patients with bad breath should use these mouth rinses to gargle very far back down in the throat and around the tongue and other parts of the oral cavity.
The good news is that most cases of halitosis can be cured, and we'll show you how to give your patients a better quality of life by fighting bad breath.
When the patient arrives at the clinic, it's of great importance that he or she blends in among the normal patients, since suffering from bad breath has a strong psychological impact on the patient, and they have to be treated with the utmost discretion. The dentist starts by going through the medical form that was included in the appointment confirmation the patient received at home. The questionnaire is designed especially for halitosis patients. It covers oral hygiene, eating habits, questions about present medication and diseases, if the patient has tonsil problems or has had them removed, if she has sought medical help for her problem elsewhere, for example with a gastrointestinal specialist. It covers her working conditions and the possible presence of stress factors, and if she suffers from mouth dryness on a regular basis or just now and then. There's a special section for women which takes up menstruation and pregnancy, and whether the patient is on hormone medication because of menopause. These factors may have an impact on halometer readings and should be noted. After this in-depth study, we then examine the oral cavity. What kind of oral hygiene does the patient have? Is there gingivitis, periodontal disease, or food impaction? Are there improper or faulty restorations? If necessary, X-rays are taken. Look for excessive bacterial growth and discoloration of the tongue. Look for signs of infection in the throat or around partially erupted teeth. Look for nasal infections or postnasal drip on the very back of the tongue. Then use our finest instrument, the nose, and smell the patient's breath. The human nose is a good odor judge. We possess an acute sense capable of detecting and distinguishing odorants. Identifying particular odorants may be difficult, but there are some characteristics to guide us, such as a fishy smell, or the smell of rotten eggs, or even of a barnyard. These findings are noted on our tongue chart, together with the areas of excessive bacterial growth and discoloration. When we've noted the findings, we start with the halometer. A straw is inserted into the patient's mouth, not touching anything. The patient holds her breath and breathes through her nose. To get an average, take 3 different readings. A printout of the results is reviewed together with the patient. There are other ways to find out if the patient has VCS in the oral cavity. One is an agar test, where a sample of the tongue coating is taken with a cotton swab and placed in a test tube. You then time it, and the sooner discoloration starts, the higher the concentration of VCS the patient has. Another way is to take a bacteria sample from the back of the tongue and look at it in a microscope. You are then able to actually see the bacteria. Then use the chairside deep tongue cleaner connected to the ultrasonic scaler. Start at the very back of the tongue and work forward. This does three things. It mechanically cleans the tongue, it cleans the tongue with high-pressure water and air, and micro-vibrations penetrate to the very depth of the tongue's papille. This instrument alone is a fantastic tool that can be a complement to every clinic and should be a part of every dentist's and hygienist's equipment. Next is the deep tongue cleaning program. The tongue is cleaned all the way to the very back with chlor dioxide swabs. This is done 3 to 4 times with a new swab each time. Finally, educate the patient on the use of the Sarcool tongue scraper. Show the patient how to make this part of a routine cleansing program. Treatment is now completed, and we now give our patient a recall checkup appointment. The patient receives the tongue scraper and all the information needed for successful home treatment. How do you find a natural way to bring the subject of bad breath up without offending the people suffering from it? Start with the patients you normally treat at your clinic. Add 2 questions to your general medical form. 1. How would you characterize your breath, good or bad? 2. Is your tongue clean and pink, or is there a white, yellow, or brown discoloration? When together with your patient you go through the medical form, it makes it easier to approach the problem. By bringing it up in this way, you don't intimidate the patient. Once you've begun treating your own patients, they'll spread the news of their positive experience at your clinic. Sign up for the European Breath Clinic newsletter and the International Society of Breath Odor Research, and keep yourself informed about new discoveries, new methods, and new products.
How do you start treating breath disorders at your clinic? Well, there are no large investments involved. In fact, the biggest investment is in the know-how, and treatment can be incorporated in every clinic. The oral cavity is all about balance, and once that balance is disturbed, then bad odor can result. In the US today, there's a $1 billion industry in mouth rinses, but it's widely known among professionals that few of these actually do anything to cure bad breath. There are, however, products which are effective, and in recommending a product to your patient, it becomes your responsibility to watch over developments and follow up with treatment to ensure best results in every single case. Treating breath disorders is a new area in dentistry, and one that's been totally neglected in Europe. But as a dentist, you're going to find that this is the single greatest opportunity you will have to improve the image of dentistry, raise patient satisfaction, and increase profits. We're facing a new millennium, and hopefully halitosis is finally going to get the professional attention it deserves.